Forum mainly aims at Community Nutrition Forum mainly aims at food educating general public in Kerala, and we educate schools, students, officers, women's, and we also follow the central government's Poshan Pakwada, Poshan, all those panchayat and all those things regularly to food educate. And along with that, we also empower our own fraternity with the two different initiatives in a monthly basis. One is Diet-O-Pedia on the current trends, case studies, and clinical guidelines and updates. And second one is Researchopedia, which is our regular small unit of research where we present journal club discussions and we initiate our papers on the Pan Kerala studies. And we have already published two studies, and now we are moving forward. Thank you so much for associating. We are happy this time we are associating with Ayyappan Kozhikode chapter, the newly formed chapter. I welcome all the president, vice president, anybody who is joining us today, every member particularly. So now I invite Miss Sherin Thomas, who is the president of Community Nutrition Forum, who is the strongest pillar and to welcome us. And she is also the secretary of Ayyappan Kozhikode chapter. She is a senior dietitian from Kozhikode and she has mentored many people here. Welcome you, Gigi.
Thank you, Sri. Yeah, thank you, Sri, for the kind introduction. And I'm just officially going for my welcome address session. So, good evening and warm welcome to all the distinguished participants from Community Nutrition Forum as well as Ayyappan India. Joining us today for the Diet-O-Pedia session organized by CNF Kerala. It is a pleasure to have you all with us for the important educational program that brings together evidence-based knowledge and practical insights in the field of nutrition and healthcare. Today's topic is GLP-1 agonist and nutrition therapy. This is highly relevant in the current healthcare landscape, given the increasing prevalence of obesity, diabetes, and metabolic disorders. Understanding the integration of pharmacological advances with nutrition therapy is essential for achieving optimum patient outcome. On behalf of Community Nutrition Forum Kerala, I extend my sincere gratitude to our speaker, all the participants, and the organizing committee of CNF for making this session possible. I am confident that today's lecture will be informative, enriching, and beneficial to all of us. Thank you all for your presence and active participation. Let's begin the enlightening session. I'll just introduce the speaker also now. It's my privilege and honor to introduce our esteemed speaker and my friend of today's session, Dr. Vinita Krishnam. Dr. Vinita Krishnam is a highly respected clinical nutrition expert with extensive experience in medical nutrition therapy, clinical practice, teaching, research, and professional leadership. She is currently serves as Chief Clinical Dietitian at SRM Institute of Medical Science since Chennai and is head of the postgraduate department of clinical nutrition at SRM Institute of Science and Technology, Vadapalani campus. Dr. Vinita also serves as Vice President of Indian the Association of Parental and Enteral Nutrition Ayyappan, Chennai chapter, and is a member of professional advisory boards of Tamil Nadu State Allied and Healthcare Council. Her areas of research and clinical expertise include critical care nutrition, oncology nutrition, perioperative nutrition, obesity management, and nutrition assessment. She has significant scientific contribution to the field of nutrition through her publications and academic work. She is the author of several valued books, including Nutrition Planning Aid for Practicing Dietitians, Cancer Diet Therapy Manual, Recipe for Diabetic Reversal, Diet Therapy for Common Disease in Tamil. In addition, she has published 5 original research papers in index journals and has presented 14 research papers and posters at national and international scientific forums. Today, she will be sharing her expertise on the topic GLP-1 agonist and nutrition therapy, an area that is rapidly transforming the management of obesity and metabolic disease. We are truly delighted to have such a distinguished expert with us today. Friends, please join me in extending a warm welcome to Dr. Vinita Krishnam. Ma'am, the floor is yours.
Thank you, Sharon. Thank you. Thank you, Shija, for such kind words. Yes, I'm indeed, listening in wow, like how Kerala is doing such a fantastic job. Though we have so many, organizations here, communities in Tamil Nadu, we don't connect so often. And it's really inspiring to hear such things are happening in Kerala. And I'm proud that I'm also a Kerala. So joining in, yeah. So today's session is basically a friend, what to say, I've not gone into research papers as such, though I read through research papers, I've not put much of papers here. I thought it should be a simple thing because GLP-1 is something which is, catching up now. It is ongoing. It is coming up now, and more so since they have removed the patents for these drugs. It has become more common. Many companies, they say around 41 companies have come up with this. 41 companies have come up with this new drug, with the same drug, the generic generic drugs have come. So I think this is going to catch up, and we need to see how, as dietitians, we can help these people come over the nutritional deficiencies, the so-called nutritional deficiencies after undergoing this therapy. What I understood from many talks, podcasts, and listening to experts is that this has been catching like a wildfire, and people are really willing to do this in spite of doctors saying that it might have certain side effects. Still, the people are ready to use this both for medical as well as cosmetic reasons because it's got such immediate effects. So going into the topic now. So learning objectives for today will be, by the end of the session, participants will be able to understand.
Ma'am, have you switched on your PPT?
Yeah, I have. You are not able to see?
Yes, ma'am.
Not able to?
1 second. Let me stop mine. Yes, I have stopped mine.
See if now it is seen?
No.
No?
No.
Okay, then I do one thing. I'll share again.
Yes.
Is it seen now?
Yes.
Yeah. So can I go ahead?
Yes.
So I need to hide this. Yeah. So the learning objectives for today will be by the end of the session, the participants will be able to understand the nutrition implications of GLP-1 therapy, identify common dietary challenges, prevent protein and micronutrient deficiency, preserve muscle mass during rapid weight loss, and develop individualized nutrition care plan. So this is something which is very, very common, not only men, women also it has become a it's become a great problem nowadays. Indian pot belly, from status symbol towards a silent killer. It is no more a status symbol, it's become a silent killer. So going into the statistics, the obesity crisis in India is ballooning, and the seemingly harmless pot belly may be a far bigger villain. Approximately 23 to 24% of Indians in the middle age, from the I would say teenage to middle age, 15 to 49 years, are overweight or obese. And abdominal obesity is extremely high, affecting 40% of women and 12% of men, especially in the urban areas, because of our lifestyle and eating pattern. Southern states, especially Kerala, for example, Kerala, 65.4%, and northeastern states like Punjab, 62.5% have higher rates than central regions. I'm sure that is the reason, I think, why they've selected this topic for today. And a study found a high prevalence of metabolic obese normal weight individuals. So they are normal weight, but they are metabolically obese. So that is around 43.53%, which is quite alarming, and suggesting many Indians are thin fat because they are low in weight but high body fat is there. Again, all because of the way we eat. The way we eat, as well as the the genes, the genetics. Okay, all this has contributed to our this kind of thin fat status in India. So the obesity triggering factors, South Asians, including Indians, tend to have more body fat for the same BMI as white Caucasians. In South Asians, fat tends to collect around the trunk and under the skin, but not always deep in the abdomen as visceral fat. See, actually what I heard from an expert yesterday, like Dr. Mohan from MB Diabetic, Dr. Mohan, where he stated that in India, the basic problem is when compared to the westernized, so the same BMI, when compared to Indians, what happens is our genetic makeup is such that our visceral fat, the number of fat cells, or we can call the adipocytes, these cells are lesser in number when compared to the Western area. So when they eat like what we eat, the fat gets stored in the adipocytes, in a large number of adipocytes, and so only the external area, the area which we're able to pinch and take the fat mass, that area is more, but the visceral fat is less. But in India, the adipocytes are lesser. So what happens is whatever is able, the fat, whatever is able to be stored in the adipocytes gets stored. The rest is being pushed into the visceral area, especially the liver. Then when the liver is overloaded, to go to the pancreas, and we know what the result will be like: pre-diabetes, diabetes, and all kind of complications. So this has been proved by studies and advocated by experts. So Indian physicians say abdominal obesity is rising due to lifestyle changes, and this is topped over. One is gene, and this is topped over by more junk foods, takeaways, instant meals, and greasy home cooking, urban lifestyles, carbohydrate diets, heavy diets, and sedentary habits. All of this is nothing new to us, and this has been happening even in our day-to-day life, because our job pattern also has become more sedentary. So now coming to screening and assessment. So what do we do? So once we, when patients are sent to us, there are two kinds of patients who take up this GLP-1. So they are, one is for weight loss or cosmetic regions. The other is genuinely health goals, where they have severe obesity, which is leading to problems like sleep apnea, then uncontrolled diabetes, severe cardiac issues, then COPD, etc. So for such cases also, these medicines have come into help. So when they come for an assessment, screening and assessment to us, what we do is, first we need to screen what literally a patient wants. Whether he wants a weight loss or he wants a want for health goals. So again, I heard from a doctor who is a good bariatric surgeon who's also practicing using GLP-1 simultaneously. So what he feels that when the first thing what he does is, he speaks to a patient for literally half an hour to 45 minutes, where he tries to find out if this is going to be for a patient, if he's really genuinely wanting it, or it is a pastime for us, for the patient. If it is a pastime and he feels that he cannot avoid for food, so he cannot resist high intake of high saturated fats or sugary foods, then he is not a candidate for either bariatric surgery or for GLP-1. So there itself you can tick off and say they need the regular diet counseling and weight loss pattern, and not the GLP-1 or bariatric surgery. Now then, second is the baseline screening include usual dietary habits. This is what I was speaking about. Emotional triggers. Again, this is very, very important. So side by side, I'm sure Shrija is also there and she will second us about this. So this is, these are the reasons why people end up eating more. And you know, when they emotionally, down, that one thing that they're triggered to eat is either a high sugary food like your chocolates and or something. If they require a mother's hug, they're supposed to eat more of cheesy items. So this is what I've read. And then all associated relevant medical conditions. So you need to see whether the emotional reason is what is triggering them to increase in their weight gain, or any other real medical conditions like a thyroid, or they have already somebody is obese in their family, and there's running pre-diabetes running in the family. So all such things you can think, and in case they have predisposed to COPD or cardiovascular diseases, you can definitely consider them as candidates. Then comes the comprehensive examination. This includes muscle strength, muscle function, and body composition analysis. Now, muscle strength, we will see in subsequent slides also. I'll be going in detail. Then next is your lifestyle assessment. So for this muscle strength, muscle function, there are simple tests also. And of course, body composition analysis, you have the BCI machines also. So depending upon whether you are screening the patient at your hospital setting or a clinical setting or a clinic setting, you can alter the tools accordingly. But assessment of these criteria is a must. Then lifestyle assessment includes aerobic activity, how active they are, and if they are active, what kind of activity do they do? Do they do aerobic? Do they walk? Or do the treadmill, or they have Zumba, or whatever. Do they do strength training, lifting weights? Then how is their sleep status? How long do they sleep? How is the quality of their sleep? Then the mental stress. Of course, there are questionnaires for that. Then your substance use, of course, your alcohol, then smoking and all that. But again, when I spoke to the doctor the other day, he said these two also, like say abuse, substance abuse in the form of alcohol, as well as smoking. These also has come down by using the GLP-1, which was a news to me, because these act on a kind of a hypothalamus where they reduce the urge for such things. So social connect, and always, people who are extroverts are, excel better in the terms of be having less stress than the introverts. And of course, the inherent health determinants. So in case you need, in case a patient is diabetic, you want to put them on GLP-1, that's a different kind of a drug. If the patient is on weight only for weight reduction, there is a different kind of a drug. So you need to categorize and do all this homework before the patient has been approved to take either of the drugs. So now for a dietitian in clinical practice, the most feasible evidence-based combination is using a hand grip dynamometer for muscle strength and muscle assessment. So it is easy. It is a bedside tool, or even in a clinic you can use it. It is the simplest form where they are asked to press it for 3 to 5 minutes. Then you just have to use the other non-dominant hand and use thrice. 3 times and take the best value. So it is very, very simple, doesn't take much of your time, less than 10 minutes it takes. The next is your 5 times chair stand test. This is also very simple, it doesn't cost you anything. So make them sit and stand 5 times and see how they are able to, whether they're using their hands, and how long does it take for them to sit and stand. Are they able to do it without help, or things like that can be observed, and there is a questionnaire, or you can say assessment tool. You can get it from the net. It's very simple. And this is the gait speed, how fast they're able to walk. That That is, this is we can always call it as a 6-minute walk test. So this is especially seen in patients who have COPD, which is regularly followed, and I'm sure in all hospitals. This also can be used by the dietitian, doesn't require much of a tool at all. So how long? Within 30, let me have for 6 minutes, how much distance a person is able to cover and how fast is he able to do. These things are noted, and then they are arriving at a conclusion. The next is very, very simple, which is called the sarcopenia questionnaire. This is a remodeled sarcopenia questionnaire, and it's solely used only to determine the muscle mass, muscle strength of the individual. This is just a 6 questions. That's all is there in this questionnaire. And those who score less than or equal to 4, you can very well say they are sarcopenic, and they are not eligible, or they are not the candidates for using of GLP-1. So these 4 tools can assess muscle strength and muscle function in less than 10 minutes. And it also aligns with the international sarcopenia guidelines. So once you do this, you feel that they are eligible, then you send them. If you're not eligible, then don't use them, because you're going to worsen their situation. So what are the, I'm not able to see what it is. Yeah, the common GLP-1 antagonists which are used are there are many number of things, but I've just put few things which I've come across in our hospital as well as in lectures. So the common agents is semaglutide. So there are 2 kinds of semaglutides which are used. One is the Ozempic, and another is the Wegovy. So this Ozempic is typically used only for people who have diabetes. So this cannot be used or should not be used for the people on obesity, because they have a separate drug called the Wegovy. This is used for people who wants to reduce weight. So there is a difference between both. Only I think in the slight amount of dosage which they use. Okay. So what I come to understand from the doctors is that they start with points. They start with 2.5. Then it is all injectable. If you all of you know that these are injectable. Tablets are yet to come. I think it's abroad. It is available. In India, it is yet to come, or it is already available, which is not publicized much. And these are basically injectable. So first they start with 2.5, then they go, after a month, they go to 5. It could be 2 weeks or 1 month, depending upon the doctor's discretion. They go to 5, then the 7.5, and that they keep on stepping up till whatever the weight, target weight reduction is. So this is what I come to understand from experts. Then the similar semaglutide is relaglutide. I have not come across in my practice here. And tricepatide. This is another common drug which is used apart from semaglutide. So this is the thing is the problem here. The one thing which is why they call the tricepatide, because this is got 2 components, unlike the semaglutide which has got only GLP-1. This has got 2 things, that is GIP, which is glucose insulinotropic polypeptide. This is one component along with GLP-1. So this is a dual agonist which is being used in many patients. So the common drug which have come across is your Mounjaro. So Mounjaro is nothing but a tricepatide, which where both GIP and GLP-1 are available. So this also seemed to have better effects when compared to semaglutide. We'll see how. So the mechanism of semaglutide is it has got delayed. How does it work? It basically reduces the appetite and craving for food, including substance abuse. Why they say? Because it's got delay. It delays the gastric emptying. It increases the satiety. It reduces the appetite. When the appetite is reduced, there is reduced food intake, and when the food intake is reduced and controlled, there is improved glycemic control. And the studies have shown that by using semaglutide, there is a decrease in HbA1c level by 1 to 2%, and there's a average weight loss which is around 10 to 15%, depending upon the agent use and the duration, as I told you earlier. Then when we come to the tirzepatide formula, that is the GIP plus GLP combination. This has more benefit when as far as studies are concerned. So it enhances the insulin response. So it can be used by diabetes. It improves adipose tissue metabolism, may improve insulin sensitivity, may contribute to greater weight reduction. And the studies say that clients lose up to 20 to 25%. And the HbA1c is also better, where the levels have dropped up to 2.4 to 2.6% when compared to the previous drug. So why nutrition therapy matters? Now we see who are the candidates to be used and what mechanism this GLP does. Now we'll go into our role, which is why are nutritionists more involved in this kind of therapy. So these are GLP-1 medications are, quote unquote, are not weight loss alone therapies. They have potential consequences along with that. Though it may look rosy, it has got many potential consequences, like there is reduced calorie intake, inadequate, because of this total intake of calorie is reduced, there is inadequate protein intake, then micronutrient, because macronutrients are less, there is micronutrient deficiency. And these patients have either vomiting or nausea, which I would see in the subsequent slides, and the intake of water per se also is less, and therefore they are more prone to dehydration, and there is lean body mass apart from the fat mass loss, and they have severe gastrointestinal symptoms. And these gastrointestinal symptoms, as per doctors' notes, say that when the patient is on 2.5, that is the initial dosage of injectable medicine, what happens is they show severe symptoms or the GI symptoms. And once they tolerate this and they're counseled that this is going to be a part of the therapy, and there are some may discontinue at this stage, some who are continuing, they cross the stage. So when they go, when the medicine is stepped up to 5 milligram dosage, then the symptoms are literally nil. They're very able. They are usually, they are immune to such symptoms. They're quite happy at this stage. But again, when it is stepped up to 7.5, again the GI symptoms come back. This is what the feedback I got from the doctors. So nutrition support, hence nutrition support is very important in such cases, and nutrition support improves adherence and outcomes. So what are the key nutritional challenges which we face as dietitian is these patients have reduced appetite. So patients often report to us for early satiety. And because they don't feel like eating, they tend to skip the meal. And they also say that in case we counsel them and coax them to take the required meal, we say them otherwise they'll be nutritional depleted. They again come back to us saying that they have food aversions, they're not able to take food at all. And in case they're able to take also, their portion size is very much minimal, and they say, I'm not able to accept that food, and the sight of the food is not appealing to me. So because of all this, there are certain consequences which has been recorded in research. That is, they have low protein intake, the low fiber intake, inadequate micronutrients, and all this leads to continuous fatigue. So being dietitians, I need not tell you the consequences of all these low protein and fiber intake. Then now, when so once the medicine, and we have screened the patient, and now we go into, then we assess the patient, then now we can go into the therapy. We give them the medicine, then we counsel them for all whatever, nutritional deficiencies that can occur. So once the patient is on the drug, then we need to assess the patient in detail. First, what we should do is we should take the anthropometric, weight, BMI. But BMI nowadays, as all of you will agree with me, is not a marker of health or nutritional status. So weight, definitely hip circumference and waist circumference has to be taken, and then if possible, body composition analysis has to be done. So then, as I told you, if you don't have anything, you can always go to those five tests which I told you, like your SARC-F, that assessment or gait or 6-minute walk or whatever. So now, then you note for clinical symptoms like the GI symptoms, your muscle strength by using your hand grip, and functional status by using those 6-minute walk test or chair test. Then also ask them to get their values biochemical workup done every 3 months. So this is to be done, like what are the results you should check for is the HbA1c, iron status, vitamin B12, vitamin D, albumin or pre-albumin cannot be done in India. Rather, it is very costly, so we don't go for it. Albumin test. Then, and in dietary, you have to monitor their energy intake. According to me, you can start monitoring the energy intake as soon as they come to you for a session, so that you can have a regular, conversation with them. Like you can pep up them, saying that you can come over to this phase and it'll be easy. So that so all this can be done if you have a one-to-one session with them, or either telephonic conversation. So energy intake. Say I keep recording every 15 days when they come to me. Then similarly, that goes by protein intake also, where they may maintain a diary and come back to me, and then we just roughly check. We also have an app where I trigger a link to them, message to them, and they will log on to that link, and they enter the everyday, protein and calorie required. I mean, intake. For example, if it is idli for breakfast, lunch, and dinner, they enter that, and then that automatically we have tagged on this metrics to nutrition metrics into that. So automatically they can see how much calorie, protein they have taken. So that is alerted to us also. We also check in case they're deficient. We again trigger a call back to them or message them, and then we coordinate. This is how it has been done. And hydration status, of course, it is very, very important. That's why I keep on repeating hydration statuses in all my slides. Then the new focus is on body composition so success is not weight loss alone. This is all of us as dietitians will agree to this fact that success is not weight loss alone. Then dietitians should monitor the fat mass reduction, lean mass retention, muscle strength, and physical function. All those I have spoken earlier also. This is very, very mandate for us to tell that the patient is having a healthy weight loss. Because believe me, friends, all of you know that in case they lose their lean body mass up to about 30%, at 20%, then the immunity is gone. 30% there's delay wound healing, and 40% they end up in major diseases, so they can come to the ICU also. So we should not be a cause for that. We need to measure their muscle strength on and off, at least once in 3 months. So lean mass loss is an emerging concern as per studies. So studies suggest that 25 to 40% of weight loss during GLP-1 therapy may come from lean tissue if preventive strategies are not implemented. That is why dietitians are very, very important. And now you would have seen that companies are coming up with supplements which are meant for GLP-1 patients. So the risks are sarcopenia, reduced metabolic rate, physical weakness, and one more thing is weight regain after discontinuation. So there are studies which clearly say that weight reduction through medicine is as well as bariatric surgery. It is easy to rebound unless they maintain their diet pattern and maintain their exercise pattern, where diet pattern scores more. Again, I'm not telling these are words coming from doctors who practice this. So the effect on body composition, this was a very recent study which was done and published in 2025, where they have done not 1 or 2, but 2,258 patients were included on this GLP. And what they found was there was a significant reduce in the total body weight. Somewhere around mean was around 3.55 kgs. There was marked fat loss around minus 2.95 kilos. preferential reducing visceral adipose tissue, and a modest proportional decline in lean body mass. Also, there was a decline in lean body mass of around 0.86 kilos. So resting energy expenditure is largely maintained, with some reports of increased during prolonged therapy. So initially, the resting energy expenditure is low, and you know that when they as they increase, it is increase. As long as it is low, it is fine. As long as if it is increasing, then the weight loss becomes even more tougher. So during prolonged treatment, it is they say that it increases. So in both diabetic and non-diabetic population, GLP-1 improve metabolic health without accelerating sarcopenia. So this is what they found in this study. And potent GLP-1 such as a trizepatide and semaglutide demonstrate greater overall weight loss, but are associated with significant reduction in lean mass. This is the study which was done by Karakasis, and which was published recently, and in 2025 in the Journal of Metabolism. So we can see everybody agrees to the fact that there is a reduction in lean body mass along with fat mass and weight loss. So how do we stop this as dietitians? So first is begin each meal with 20 to 30 grams of protein. So every meal. Okay, so for a normal individual itself, we need about 20 grams of protein to reach our target. But for these people, you ensure that they receive 20 to 30 grams of protein each meal, underlining each meal. So include this, you can of course include foods like fish, beans, chickpeas, tofu. I'm sure you'll know all these. Then, but aim for 1 to 1.5 grams of protein per kg of body weight for a moderately active individual. For a physically more active, you can go up to 1.8 to 2. Then use protein shakes with at least 20 gram protein per serving. And whey protein, I heard, is more beneficial because it has got leucine, which I'll be telling you in the subsequent slide. So whatever the case may be, you target for 20 to 30 grams of protein, and that too it is per meal, and by some source you attain that. So now leucine and muscle preservation. So leucine is supposed to be very, very important in preserving the muscle mass, and that is a precursor for, you'd have heard of the HMB, right? So this is a precursor for that also. So leucine is the primary trigger for muscle protein synthesis. So it triggers the muscle protein synthesis. So again, in diabetic patients, if you know that the insulin sensitivity not only prevents or increases the assimilation of sugar or glycogen in muscle and the liver, it prevents or masks the acceleration for protein synthesis. So there is increased proteolysis, but it somehow or the other prevents protein synthesis. And that's why all these diabetic patients, you would have seen them, they're losing a lot of muscle mass unless they take care of their protein. And here, and exercise, of course. So here they say leucine is the one which prevents, or it acts as a gate, or security guard. It opens this gate and allows the muscle synthesis in patients. So the rich sources of leucine are again whey protein. Whey protein is whey protein isolate and hydrolysate is the best. Of course, it's costly. You can use it for children and geriatrics. Then the next source will be whey protein isolate. Then comes the whey protein concentrate. Whatever form it is, whey protein would be the best choice, followed by milk, paneer, yogurt, eggs, fish, poultry, okay, and you target around 2.5 to 3 grams of leucine per meal. So again, it is per meal. You have to target that they get 2.5 to 3 grams leucine per meal. And if it is HMB as a component, you try to get around 2.5 to 3 grams per day. So that's the difference between leucine and HMB. Okay, now protein distribution strategy. How do we attain it? Just a rough sketch I've done. I'm sure you will know better. So aim for 25 to 30 grams of protein by meal. For example, in breakfast, you can include eggs and milk. Of course, Greek yogurt. Why again I put it here? It is no more a Western food. That's got so much of beneficial bifidobacterium. So please include them. All of us also can take it. Whey protein shakes for people who they feel their appetite is too low, they are not able to maintain, or the quantity they take is very less, then the best is to put them on some protein shake. Then lunch, you can give them fish, chicken, dal, if it's a vegetarian, dal and curd. Dinner, again, lean protein source and legumes. Okay, so these are, and doctors say that leucine is better available in vegetarian sources. So might as well give them vegetarian sources for dinner than opting for non-veg sources. Then benefits, yeah, better muscle protein synthesis, improved appetite management. So now next comes energy balance. These medications, all of us know, reduce the appetite. So how do we manage the energy? We manage by eating small meals plus snacks. It could be nuts, fruits, unsweetened yogurt, because that will give you the probiotic also. Then choose slowly digested carbohydrates like your sweet potatoes, oatmeal instead of refined grains, white bread, pastries, etc., or sugary drinks that can cause blood glucose swings, especially in diabetic people. And to feel full longer and healthy fats, for them we need to follow something called like your Mediterranean diet, where olive oil, in case any, of course in Kerala we can use our sweet coconut oil also. So nuts and seeds to meals. So how do we manage now we come to the managing of symptoms like nausea and other GI symptoms. So the common effects we have highlighted earlier, like nausea, vomiting, bloating, and constipation. So I've spoken to many of the colleagues in a hospital who are put on these drugs. They also say that they have severe bloating and constipation, and nausea, vomiting was not there much for many of them whom I interacted. But the bloating and constipation was a very big problem for them. So that again, for constipation, they had to take medicines to relieve it. So what are the nutritional strategies? Some frequent, small frequent meals, like how avoid high fat meals, eat slowly, avoid lying down after eating, because these people have some heartburn also, because they feel that the food is, the stomach is always full and something is pushing up. So they have this heartburn is another problem they tell us when they come to us. So avoid lying down soon after eating, and use ginger base. We ask them to take the ginger infused tea. So ginger based foods and when appropriate. So all this can relieve their symptoms to a large extent. Then constipation, why? Because this is caused due to reduced food intake. Because of reduced food intake, there's reduced fiber intake. And more so, we spoke about hydration right here. So these people are severely dehydrated, either due to nausea, vomiting, either they puke or they throw up, or they visit the restroom where they have increased bowel movements, and some have constipation. All this result in dehydration. So naturally, this leads to constipation. So hence, we need to recommend to them to take 25 to 35 grams of fiber per day through vegetables, through intake of vegetables and fruits and whole grains. Psyllium supplementation if needed, because this is very common. It's just a natural source, and patients don't get addicted to it more. That's what we get feedback. They don't get addicted, unlike other drugs, medicines. So hydration strategy, very, very important. So delayed gastric emptying plus reduced intake can increase dehydration risk. So our target would be 30 to 35 ml per kg per day of fluids. Okay, they can take it in the form of water, they can take it in the form of soups, they can take it in the form of unsweetened juices, and of course, fruits and vegetables which have more of water contents. And this more during exercise, this has to be, they should keep on sipping up some ORS or this fluids, water, to prevent dehydration. So how do we ask them to monitor? We ask them to monitor the urine color, which is very, very simple. In case the urine color is pale yellow, then find they're well hydrated. If it is dark yellow, then they need to hydrate themselves. They can also come up with symptoms like dizziness due to dehydration and constipation, of course. So micronutrient, because all of the macronutrients are compromised, naturally micronutrients also be compromised. And for GLP-1, for those people who are on GLP-1, we need to monitor the vitamin D, B12, iron, calcium, magnesium, potassium, because they have a lot of diarrheal outbursts, and particularly in patients consuming less than 1,200 kilocalorie per day. So these patients whom you prescribe less than 1,200 kilocalorie per day, or for they themselves are unable to take more than 1,200 calories per day, please monitor these values every 3 months. So do we need vitamins or other supplements? But researchers and studies say that, experts say that a well-balanced, nutrient-dense diet is usually better than supplement, because it is 100% absorbed and not wasted. And but for people who are not able to take due to some reasons, then you can, supplementation is a must. So you can consider vitamin D, calcium, multivitamin if at risk, and low diary minimum. Those people who are at risk, or elderly people, or who are lost a lot of weight, they're not able to take food for some reason, then you can give them a multivitamin. And those people have seen people on vegan diet also. Vegans also have these issues. So there you can give them a multivitamin dosage. So there's something to be avoided. So diets to avoid while taking GLP-1 medication is, first is extreme calorie restriction. Never give them extreme calorie restriction, because they already will have a low appetite and aversion to food. This extreme calorie restriction can worsen dehydration, fatigue, and lead to kidney, because they're because of dehydration, it ends up in kidney problems, and it limits essential nutrients, and that's why these patients are mostly fatigued. You should always avoid combining restrictive diets with GLP-1 medications, which can result in excessive weight loss. And strict vegan diets can cause vitamin B12, iron, and protein deficiency. So you need to counsel all these to the patients when they come initially itself. So next is without exercise, of course, nothing is complete. So exercise plus nutrition is the best outcome. We know what kind of exercise is useful there for them. Of course, resistant training is essential. So recommendations is 2 to 4 sessions per week, where they should focus on major muscle groups like your triceps, biceps, etc. Progressive overload, they need to keep on stepping up. As they step up this medications, I said 2.5, 5, 7.5, etc. They need to progressively step up their weight training also. Then this should be combined with adequate protein. Resistant training significantly reduces lean body mass, and that is why you need to combine them with adequate protein. Adequate protein is very much essential. So even when you're giving them HMB supplements or whey protein supplements, they work best only when you give adequate protein. If you feel that I'm giving whey to the patient or HMB to the patient and I leave it at that, it doesn't work. Protein plus whey or HMB only. Adequate protein, I would put in that way. Adequate protein plus these two combination works better than standalone whey protein or HMB. So exercises, this is the stepwise exercises, a rough glance about that. To retain muscle and overall health, a 3-step approach to exercise is stated here. Step 1, gradually increase moderate activity like brisk walking, because when you walk, the best way to reduce your fat is walking. There's no exercise beyond this. Starting with 10 minutes daily and building to 150 minutes weekly. Experts say Indians need tougher lifestyle changes than Westerners. That is because, as I told you, for us, visceral fat is more when compared to this adipose tissue. So visceral fat, we need to really work double than the Westerners, so to bring out that fat. So norms recommend that around 250 to 300 minutes to offset slower metabolism and less efficient fat storage. So much you need to do when if it is 150 for them, for us is 250 to 300. Nearly double. Then step 2 is strength training 2 to 3 times weekly for 30 minutes using bands, simple bands, weights or body weight exercises like squats, lunges, etc. Everything is available in YouTube. We can always ask we need not tell them, you can ask the patient, tell them the name and ask them to see the YouTube and get it done. Then step 3 is maintain progress with 30 to 60 minutes daily activity. Maintenance very, very important. If they stop this, they're going to regain the weight, whatever said and done. So maintain that happens if it is just diet and exercise, weight loss can be maintained for 1 year post your cessation of your diet plan. But in case you're taking medicine, it is just 2 weeks or 3 weeks, even a month earlier. Okay. So maintain progress with 30 to 60 minutes daily activity and continue the 2 to 3 weekly 30-minute strength training exercise. So strength training exercise to be continued, and your aerobics or simple walking also for an hour is a must. So what are our monitoring schedule as dietitians? Baseline, we spoke about weight, body composition and laboratory values. I spoke about earlier. And monthly is your dietary review. First, I would say initially do it for 15 days. Once you feel the patient is on track, then go to monthly dietary review, side effects, and protein adequacy. All this can be checked by even your dietary recall method and or your any apps which you used, as I spoke earlier, where you can calculate and let them know. And any side effects they have, you can always highlight with the refer them back to the physician. Then every 3 to 6 months, you check the micronutrient deficiency, muscle mass assessment, we spoke about the tools again, and functional assessment again, we spoke about the tool. Muscle assessment is hand grip and functional assessment is your walk test. Again, when they come again after that, do reassessment. Assessment, reassessment is our job. So do again reassessment. What do we monitor in reassessment? We are monitoring for adverse side effect and nutrition counseling, preventing nutritional deficiency, track using a smartphone application, which is always available now, paper and diary maintenance, which is very simple for people who are not tech savvy. This is always useful. Or nowadays you take a photo and send it and the app calculates how much your intake is. And in case you are doing it at a hospital level, you can always go for body composition analysis. DEXA is the best. So the practical take-home messages, the 5 P's of nutrition therapy has to be followed. What are they? Protein first, preserve the muscle mass, prevent deficiencies, promote hydration, and personalize care. One size doesn't fit all. So you need to talk to them, personalize their care, and then, only then they will stick on to your diet pattern. And GLP-1 medication work best when combined with structured nutritional therapy, resistant exercise, and long-term lifestyle support. So these are the references, and thanks for patient listening.
Thank you
Any
so
doubts?
much, ma'am. Thank you so much, ma'am. You have done a beautiful explanation. So, almost now it is a good time. We are all seeing the GLP-1 patients and coming across many taking the drugs and all those things. So there are some fears among our fraternity that will the drugs going to replace the dietetic practice? What is your thought on that?
Yeah, can you see me?
Yes, yes. Just stop your screen share, ma'am.
Yeah, stop screen share, no, this definitely cannot. So that's what I said. If we have what to say, our input is definitely required. AI can work only based on our input. So that cannot replace. In case AI can definitely tell this has been, the protein intake is less, your carb intake is less. Now only we can decide what kind of protein has to be supplemented for them based on their reports, based on the intake pattern, based on their physical activity pattern. So definitely AI cannot replace our work.
Thank you, ma'am. There are some questions in our chat box.
Yeah.
So the first one is, do you routinely monitor for micronutrient one second. Inadequacies in patients who experience substantial appetite suppression?
Yes, we do tell them, and we tell them to get their labs done. First, when they come itself, we ask them to get the labs done. After 3 months, we again ask them to get the labs done. And then at least for their vitamin B12, calcium, vitamin D. Then 6 months iron, yes.
So when the patient reach a weight loss plateau, what nutrition related factors do you evaluate first?
Yeah, nutritional factors, when they reach a plateau, we need to definitely tweak between the diets. As I see, body also is very smart. What it does is it will definitely, understand that, this is going to be diet pattern, and such amount of hormones and such amount of GLP and leptins are secreted. So what we do is, what generally I practice is, I cheat by changing the diet. I either in case they have been taking breakfast more, and in case I usually what I do is either restrict them, whatever meal they're taking more, I restrict on them. And when they are on like that, and there has reached a plateau, suppose they're taking lunch more and I've reduced the lunch, what I do is I ask them to skip dinner by taking just the fruits and give them some lunch, adequate lunch, protein lunch. So like that, I play around breakfast, lunch, and dinner, rotating, so that and increasing the activity, physical activity. So I start with 30, then I go to 60. Then along with 60, I introduce some kind of resistant exercise there also. Then include pranayam, yoga. So something different where the body, where we cheat the body and say, no, we are not following the same thing, and you better not secrete the same amount of glucagon or leptin or whatever.
Okay, thank you. So you are trying to dictate your brain.
Yeah, play with psychology like Shrija. Yeah.
No, Sri Priya.
Shit.
So does GLP-1 intake have an impact on IBS?
Yes, GLP-1 is not recommended for patients with IBS.
Exactly. So 20 years from now, do you think dietitian will still spend most of their time helping people lose weight, or helping people enough of the right nutrients while on highly effective weight loss medication?
We will still be talking the same theory, because again, I would say that Dr. Mohan from MP Diabetic Center, I happened to listen to his lecture where he said the genes are a factor. So now, initially only one, the father was very active in the fields, and the mother was at home. So what happened? Like their children, one part got the gene of obesity, okay, from the mother. Now both the mother and the father are obese, they have different diseases. So the offsprings are going to be even worse, and their offsprings are going to be even more worse. So it is gene playing a part. So nothing can change this. So only saviors for them, apart from their environmental and moreover environment, even pollution is again causing so much of diseases, including obesity, is what this studies say. So definitely we have a lot of job to do, whether it's 20 years or 25 years ago, later. Dedicated dietitians definitely have a role to play.
Okay, I think we have more role to play on preventive health also.
Yes, exactly.
Okay. So the next question is, if the patient discontinues this injection, can proper dietary management and regular physical activity help prevent recurrent weight gain?
Yes, they have to, but now all the studies have shown that increase in weight is eminent in patients who stop GLP-1 drugs, and only diet maintenance, diet restriction plus strengthening exercise can help them retain the weight.
Okay, the next two messages were your appreciation for your insightful talk. So the next question is, what calorie intake is recommended as they have no appetite?
Pardon? What?
Calorie intake is recommended as they have no appetite.
What calorie intake is recommended? I said no appetite. See, that's what, again, it is a usual thing only. You have to take care of the patient's height, BMI, what percentage of weight they need to lose. Based on that, you decide on the calories. So calories is not based on the appetite itself. So you need to, based on the percentage of weight, target is the target weight, how much they have to lose. For that, how much calories you need to restrict. That workup you have to do. Then you do, then you somehow give the calories to the patient. So you either, that's what I'm telling, only in the first phase, that is when they're on the 2.5, that initial 1 month phase, they have a problem. But then they get used to this kind of a diet. So we don't have much problem in coaxing them to take food. So you give them good food, like the same thing which we come across people who are, adamant in taking food, like our children or our elderly parents. So just make the food more appetizing and give them calorie dense food. For example, instead of giving them bad fats, you give them healthy fat, which give them 9 calories per gram, all of us know. So give them more of healthy. Such cases, you address them by giving more of healthy fat, so that more calories they get from the small amount of food they take. And protein, of course.
So GLP-1 is applicable for pediatrics?
They say it is allowed only after 15 years. Though abroad they're using it, but Indian doctors advocate it only after 15 years of age.
Okay. Next question is, can you brief on the nutrition intervention in gastroparesis after GLP-1 therapy?
Gastroparesis after GLP-1 therapy, the nutrition intervention. So that's what we exactly spoke about throughout the session. So we have to give them small meals at regular intervals, give them calorie dense meals, give them in worst scenario, give them supplements rich in whey proteins. So this is how we tackle them. And repeated counseling is required, because they'll have nausea. One time they come back with constipation, and then they say if the fluid intake was not enough. So all this repeated, that's why I say repeated, you have some kind of communication with them on a regular basis, and it is very easy. It is not very tough to handle these patients.
So how does GLP-1 affect basal metabolic rate long term? Do we need diet breaks or refeeds to prevent metabolic adaptation? That is question number 1.
So BMI, that's what the studies have shown, that long run it does affect. We need to, still we have not entered into such things at all. It's just the study is on. So maybe in future we will try and find out reasons for this once this has become a chronic problem. So as of now, do we need diet breaks or refeeds to prevent metabolic adaptation? Maybe we can try it. No harm in doing it.
Okay. So she has posted another question. What biomarkers should we track to assess nutritional status on GLP-1 therapy apart from glycemic control and body weight?
Biomarkers is the same thing which we spoke about, right? All your micronutrient status, and you can nutritional assessments can be done. Your body waste, body circumference, if you are doing it at a private clinic, or if you want to do it in your even the sarcopenia score, you do it assess on and off to see how it works. So these simple things can be done as of now. And of course, your biochemical parameters are a must every 3 months or 6 months.
There is an interesting question. Patients taking Mounjaro injection are not willing to follow a dietitian. Even doctors do not refer to us. What to do in these cases, ma'am?
Definitely, it is a loss for them, because you need to. One thing you can do is you can. What I would suggest is speak to the doctors, or you put a poster in the clinic, in their clinic, saying that how it affects the muscle mass, and just by coming to us, small screening tools we use, and we can find out earlier before they're losing. And as I told you, you can say frighten them by saying that 10% muscle mass you lose, 20% muscle mass you lose your immunity, 30% your wound healing is not there. then 40% you end up in ICU. So you can just they put in cigarette packets, injurious to health and cancer comes and all that. I think we should also put in doctors, clinics, posters saying that this is going to be a death trap if you don't come to a dietitian.
I just want to add, I belong to the clinical trials of GLP-1 drugs. So even during the clinical trials, they have never avoided, not even one single place they have avoided dietitians across maybe everywhere. I have seen it. From India, we have many dietitians in the GLP-1 drug clinical trials.
Yeah.
So I think we have to go boldly, strongly, speak on the facts and figures. And like after a certain point, as ma'am said, we can do maximum best of our education from our side through social media. Now, one of the best thing which can do any miracle, and rest is not in our hands. Okay, moving to the next question. Ma'am, is it helpful for diabetic control for a person with normal body weight?
Pardon?
Is it
Just
helpful
for
for
diet.
diabetic control for a person with normal body weight?
Normal body weight, yeah. See, as I told you earlier, Indians are thin obese, right? They're called thin fat people. So we need to assess them thoroughly, and then once you assess through your assessment category, if you find them they are obese, sarcopenic obese, or they may be thin, but they are obese as far as their body composition is concerned. So a diabetic can, if they're thin, also definitely their muscle parameters will be body composition will be haywire. In case they are, if it is initial diabetic people, don't worry, don't bother about that. In case it is a long-term diabetic people, you need to, you can try taking that. Now many of them are, because your insulin is also injectable, GLP-1 is also injectable, so people don't mind taking that option. Again, doctors will be the best judge for this.
Okay. So again, you have few more people like Shashikala ma'am, Haley, and Anita ma'am. You has given their token of appreciations to you. And
Yeah.
I think this is the last question for the day. Apart from IBD and IBS condition, are there any exclude conditions for taking this GLP-1?
That's what first thing is very simple. Those people, apart from these disease conditions, I think elderly people, they don't go. They have though doctors say we go only till middle age. And when I spoke even same question, I had a doubt and I asked him. He says I don't recommend this for elderly people because they are already sarcopenic, and those patients who have already lost their muscle mass, you should not be using them. That's why our initial screening is very, very important. And this is not used for children below 15 years. India, they're not using. I think abroad they have tried, but Indians doctors are not used.
And also in fertility clinic, they are not using. Like once they take the GLP-1 drugs, they maybe like try for fertility only after 3 to 6 months.
Hello, ma'am. Vinita, ma'am. I'm Uma Kalyani here. Can you see me?
Yeah, I can see you, ma'am.
Hope you remember me. 26 years back, I think.
Really? Okay, you look pretty now. Tell me.
Okay, actually, like I came for my internship there. After that, I joined and I was working for, I think, almost 9 months. So now I am like settled in Kerala. Nice to meet you, and you have not changed at all. The way you speak and you look the same. Like
thank you.
Yeah, really, I'm not simply saying, yeah. Actually, like I saw you in the IAPN meeting, Kochi chapter meeting was there, no, last time, the muscle loss one. So in that also, I happened to see you after so many years, and very happy to be here also today. Actually, I'm the secretary of CNF. So today I have some other family commitments. That's why I could not join from the beginning. Okay. So thank you so much. It was an excellent presentation. And welcome back to CNF in the coming days also for more informative sessions.
Sure. More than happy to meet people from Kerala, because that's my blood, right?
I know. Yeah, thank you so much, ma'am. Yeah.
Thanks a lot. Yeah.
So that's an excellent and very insightful session. Thank you. And I formally invite Mrs. Hailey Thomas to render vote of thanks. Hailey, Chechi, are you there?
Am I audible?
ഒരു ഡിവൈസ് ഓഫ് ആക്കണേ.
One second.
Haley, I think you can join through one device. ഇപ്പൊ ഇത് അൺമ്യൂട്ട് ഒന്ന് ചെയ്ത് നോക്കൂ. Ma'am, are you still in the hospital?
I'm still in the hospital.
Okay.
Okay, now is it okay? Yeah. Good evening to everyone. I'm Haley Thomas. I feel true honor to deliver the vote of thanks today. First of all, I sincerely thank our chief guest, Vinita ma'am, for taking this time to be with us by giving a wonderful session. Ma'am, your inspiring words and slides, which is very informative, and your presence also is made this occasion very special. Thank you, ma'am, from our CNF part and all of us from our side. Thank you, ma'am. And I extend my heartfelt gratitude to our respected organizers for arranging this wonderful program. And special thanks to volunteers and supporting staff to their hard work behind this program. I also thank all participants for their enthusiastic involvement, and almost 92 participants have been with us for this session. Thank you for all the wonderful participants for their involvement. We truly appreciate and encouragement and support from everyone present here. Thank you. Thank you so much.
Thank you everyone for this wonderful day and wonderful, excellent session you are joining after the beautiful weekend is starting today. So I kindly invite you all for the next 2 sessions going to happen from CNF. One is Nutripreneur. We are also giving a very interesting session on dietitians should not stick into the hospital cabins and we should move ahead with preventive healthcare. So we are doing a session on Nutripreneur like once in 3 or 6 months. So this time our Meraki team is going to conduct the Nutripreneur, which will be for next Friday evening. The pamphlet is still to ready. We'll be sending it across in the groups. So please join that webinar. And again, there is another interesting hybrid session and first of its kind in NeuroNutricon. We are happy to collaborate with the Neuronutrition Co-Group of IAPN India and Indian Academy of Pediatrics Kozhikode branch and IAPN Kozhikode chapter. So please join us in all the wonderful, excellent knowledge sharing sessions. Give your ideas, suggestions, and feedbacks, which will help us to grow together. Thank you all. Have a wonderful week ahead.
Thank you, all of you. Thank you.
Thank you all.